native of Chicagoland. Nice. Native of Chicagoland. She received her veterinary degree from The Ohio State University. See, I got it right. And then completed a year-long internship at Wisconsin Equine. Following a one-year research fellowship at Cornell, she began a 3-year equine surgery residency at North Carolina State University College of Vet Med. Dr. Peel then rejoined Wisconsin Equine in July of 2020, so coming up on a year, as an associate surgeon, and became a diplomat of the American College of Veterinary Surgeons, so we call this board certified. Her interests include sports medicine, upper airway surgery, and laparoscopy, and I can tell you that she's also marvelous with regional limb perfusion, shockwave therapy, ultrasound, because I've experienced it firsthand. So with that, Dr. Peel, I think we let you go and share screen and all that.
All right, here we go.
Judith, you need to take your picture off. Please take your video off. Thank you.
All right, do you see my screen? We good?
Yep.
Yes.
All right, thank you for that introduction, and good evening to everyone that's here with us tonight. Tonight, I'm going to discuss poor performance issues specifically related to the axial skeleton, so primarily the neck and the back. And it's a pretty broad topic, as you might imagine. So I've tried to focus on the issues that are more clinically relevant to the English performance horse. I'm sure we have a diverse audience out there, so please forgive me if parts of the discussion are too basic or too technical, and just do not hesitate to ask questions using the chat function if they arise. So what is lameness? We're kind of just going to start there very briefly, and at the most simple definition, it's being incapable of normal locomotion or a deviation from the normal gait of the horse. And it's a very common complaint that we get for horses that have axial skeleton issues, that the horse isn't lame per se, but that they're not moving quite right, whether that be difficulty picking up or maintaining a particular canter lead, difficulty with leg yields or half pass, head tossing, particularly when coming down after a jump, and or refusing a jump. And all of these things are clinical manifestations of either inflammation or pain, provided they're not behavioral in origin. So assuming they're pain related, these are technically considered lamenesses. And when we get this subset of horses that they're complained and perhaps they're a bit less demonstrative in their discomfort. They aren't maybe bucking under saddle or refusing jumps, but they're just struggling to perform to their expected potential. We have to go down a bit of a fact-finding mission because there's so many other factors that can be contributing to these clinical signs as well. So what training methods are being utilized on this horse? What's the current stage of fitness of the horse and the rider? It's obviously a partnership, so we have to look at both components of that. Saddle fit and general conformation of the horse are all important. So historical factors that we additionally need to consider are whether the horse is currently competing. This can not only impact their soundness because they can be spending several hours on a trailer hauling places. They might be working more intensely than they typically are used to, performing on various footing surfaces and depths, which can certainly impact the biomechanical forces that are at play on the limbs and then the axial skeleton secondary to that. And not only does it impact the lameness, but it also impacts the veterinarian's ability to perform diagnostics and treatments on these horses. So we have to follow specific drug regulations and drug rules, and we need to know if these horses are, expecting to be at a show in the near future and how much we can do with them based on those restrictions. So information about the last shoeing is also important. So the feet can be a particular frustration for owners and veterinarians and farriers alike. All of the forces that are transferred from the feet, again, are transferred from the limbs and to the back. And just a little bit of a depiction here. The picture is on this screen. The top image is of a hindfoot that was pre-trimming. So this horse is a horse that is a performance animal, but it is not shod through the winter given the fact that they don't show it over the winter. And they pull the shoes and let the feet grow out. And you can see that the toes are a bit longer than you might want them to be. The heels are a bit more underrun. And then the bottom image is of the same horse, same foot, after it's shot in its typical setup for show season. So quite a difference in the angles that you see there and the forces that are going to be at play. You can even see that the pastern in the lower image is a bit more upright than the image on the top, so pre-shoeing. And that puts dramatic changes on the limbs and the joints in the back and can predispose to pain or abnormalities that we might need to be considering in these horses. So a thorough clinical examination is key in these horses. We always start with, or at least I always start with, a general lameness exam, as even mild forelimb lameness issues can be present with neck problems, and mild hind limb issues can be present with back or pelvic problems. So the examination that we perform includes a static or a standing portion, as well as a dynamic portion, watching the horse go, performing flexions, and seeing how they move on a variety of circumstances. Visual inspection is also important. We look for asymmetry, which can indicate swelling or muscle hypertrophy, as well as atrophy in areas where we may not see as much muscle as we want to be there. The hands-on examination, then we utilize to feel for sensitivity to particular areas, as well as mobility of the joints, the back, and the neck. So the moving exam, it depends exactly what's going on with the horse. There are very certain circumstances where we do not do a dynamic exam, where we're concerned about fractures or significant instability in the spinal column or pelvis. But predominantly, we utilize a hands-on dynamic exam in hand on soft and hard ground, as well as lunging on soft and hard ground, as some of these behaviors or performance issues are really only evident under particular circumstances. And in issues with the axial skeleton, I often will evaluate the horse with a rider on board as well, and look at those horses in a relaxed and a collected frame, because the position of the neck and the position of the back changes dramatically under saddle and in those different frames, and can be contributing to the problems that we're seeing. So we'll stop right there with sort of general information and dig right into the equine neck. Do we have any questions to this point?
There aren't any questions so far.
Perfect. All right, so we will move on. Neck pain, we're gonna start here with a just brief anatomy review. So in the horse, the neck consists of 7 cervical vertebrae, seen here, and it connects the head to the trunk and also supports the spinal cord. The first 2 vertebrae, the atlas right here, and then the axis, have very unique shapes and functions. You can see the shape is quite different than the rest of the vertebrae as we move down the spine. The junction between the skull and C1 permits flexion and extension of the head, so moving the head up and moving the head down, and has very minimal side-to-side movement. And then when we move between the first cervical vertebrae and the second cervical vertebrae, this particular joint here it's the pivot point, basically allowing the skull to pivot around the spinal column. So the second cervical vertebrae is aptly named the axis. So the skull rotates around that axis. As we go down the neck, C3, C4, and C5 are incredibly alike in the way that they look. C6 is very similar, but it's a bit shorter, more boxy. And then C7 is the transitional vertebrae going to the thoracic spine. And you can see there is a little bit of a spinous process on this one. So that's how we know that's C7. The numbers or the particular location of the vertebrae are more important for us in trying to identify which vertebrae we're looking at on imaging. So we need to know those particular anatomy of them, but it does not ultimately affect the pathology that we see in those locations. So with clinical signs for neck pain, the most common thing we see is degenerative issues. There's certainly a lot of trauma that can occur to the neck. It's a particularly exposed area, just like the limb of a horse, and trauma is often related to either a fall or collision with another horse or a solid object like a jump. Rotational falls, especially in horses that are out there on the event course, are particularly bad sources of trauma, unfortunately, to the neck, but we're focusing more on performance-related issues in this discussion. So things that we're going to be commonly seeing and be concerned about would be abnormal head carriage or an unwillingness to work on the bit, and generalized neck stiffness or inability to bend as you might expect them to do. I briefly touched on this earlier, but mild forelimb lameness that is unable to be localized to the limb can also be secondary to neck lesions. And then a subtle hind end issue can include stumbling or weakness. Those would be more secondary to neurologic deficits when you don't see an overt ataxia or overt neurologic signs, drastic stumbling, inability to maintain the gaits or an upright position. Those mild issues can be secondary to particularly arthritic changes or advanced arthritic changes in the neck, and are something we need to consider as well. There is no perfectly symmetric horse, so we also need to be very aware of that. We see lots of asymmetric mild swellings in horses that we don't want to be led astray thinking that that is something. If there's no pain associated with that swelling or significant problem with it, it's most likely not clinically relevant. So, it's easy for horse owners and riders and veterinarians all to sort of focus in on something, but we kind of need to take a step back when we're looking at the axial skeleton, the neck and the back, and take a really focused and stepwise approach to these lesions, because like I said, it's very easy to be led astray. So again, we're not going to touch base on neurologic issues in this conversation, but know that mild deficits can occur even with arthritis of the cervical spine, but more advanced neurologic deficits, diseases such as EPM or wobblers, we're not really going to talk about so much.
There is one question. I haven't seen this, so I don't know. I think you have it in here, but if it's appropriate in a certain place, can you talk about neck issues and its relation to shivers? Do you have that in here, right?
I don't talk about shivers much, but I can certainly elaborate on that a little bit now. Okay. Yeah, this would be a good spot. So shivers is very different than cervical neck issues and back issues. It is its own clinical entity that is diagnosed via muscle biopsies and a variety of other testing done at specific laboratories. It is not, like I said, not the same as the neurologic deficits that we see with cervical arthritis or neck arthritis. They can be complicating factors though, and particularly more in the hind limb with pelvic issues. Horses can display shivers-like gaits, and that can confound diagnostics and sort of make us think that they may have a shivers disease presentation versus an SI pain or back pain presentation. And we need to really, like I said, be focused in the way that we evaluate those horses. So shivers, it's not a lameness. It's more of a mechanical deficit rather than a pain-related process. Does that help for whoever answered that question?
Oh, thank you. Yes, that's insightful.
Okay.
So thank you.
Perfect. Yeah. And if more questions about that come up, we can certainly talk about that more later on. But for now, we will move on to diagnostics for the neck. So the axial skeleton is different from the appendicular skeleton, being the limbs, in that we can't really perform diagnostic analgesia, so nerve blocks in this area. It's too close to the spinal cord, too close to the nerve roots. And if we anesthetize those, horses fall down. We have desensitization of the diaphragm. They can stop breathing. We have a lot of bad things that can happen. So blocking these areas is not generally recommended and is not something that I undertake in a clinical exam. So we're left with just performing diagnostic imaging and or treatment as a modality, as diagnostic and treatment, basically. So radiographs and ultrasound are primarily our first line of defense, and we can get pretty good information with what's going on in the neck with these imaging modalities. They're relatively inexpensive. They're pretty easily accessible. They can be performed on the farm. But when those modalities fail to identify obvious abnormalities, or there's question regarding the significance of mild abnormalities, we're often left with moving towards more expensive and more invasive diagnostics, including nuclear scintigraphy, which is bone scan, and or a CT with a myelogram. So we'll talk about those here as we go through the next few slides. So for neck radiographs, plain radiographs are pretty easy to obtain. They're more difficult for us to interpret for several reasons. One is that positioning of the horse is incredibly important. There's a lot of superimposition of the bone structures. So these are basically, blocks of bone surrounding a spinal cord, and they're basically mirror images of itself on the left side and the right side. So what we want to see when we take our radiographs is almost the exact same contour. So you can see this line here, right? We don't see the opposite side of this vertebrae shadowed behind it. Whereas in this one, we see two sort of lines here. So we're slightly obliqued on this vertebrae, which we expect to be obliqued with some of them, or at least oblique meaning off image a little bit, but your center of the picture should be ideally perfectly straight on. There's a lot of soft tissue, particularly when we move back towards the C6 and C7, so in the shoulder region and the base of the neck. And when we have problems in these areas, we really have to make sure that we're using adequate penetration with our radiology equipment, and that may require us to bring a horse into a hospital to use a more powerful machine if we can't get adequate images on the farm. But these images here, it's the caudal half or the back half of the neck. So C3, C4, C5, C6, and C7. And these are the areas where we most commonly see problems in our performance horses. C1 and C2 are not commonly implicated. They're more problematic in younger or developing horses, or specifically with trauma. But this is the primary area where we look at. The facet joints right here, these are the articulations between the vertebral bodies. So this right here is the joint space between the cranial vertebrae and the caudal vertebrae. Like I said, the spinal cord runs through the center of these. And then there is an additional articulation, which you can't see so much when you're just looking at the bones, but you can see it down here in these radiographs. So there's this projection or process from the caudal vertebrae that articulates with this surface here on the vertebrae in front of it. And that is also an area where we can see arthritic change develop. So these images are a series of radiographs with various degrees of remodeling of the caudal cervical vertebrae, the base of the neck. So for reference, remember the 6th cervical vertebrae is a bit shorter and more boxy than the other ones, and that's our reference point for all of these images. So C6 is here, there, and there. And we look at these two images here on the left. There is some mild new bone formation or new bone proliferation at the articulation of C6 to C7 in both of these, and a little bit, but more mild on C5 to C6. So these areas look a bit more bulbous, if you will, than we would expect them to look. And you can see this little bit of remodeling over the top of these regions here. The difficulty in interpreting that is that there is a large number of middle-aged to older horses. So approximately 85% of horses that we image in the 9-year-plus age range has change, remodeling to these areas that is not clinically significant. So we take a lot of images and we see very mild changes in horses that don't have neck pain. And we know that because these are horses that we're taking pre-purchase radiographs from, or horses that are in some sort of repository. So in Europe, there's a lot of repository films anytime a horse is sold. So these are images that are just obtained without any clinical reason to take those images. So we see these changes. What do they mean? it's a little difficult to interpret sometimes. When we look at these other images here on the right, these are more drastic changes and definitely more supportive or strongly supportive of clinical disease. So this one at the bottom, see my cursor here. So you can see this area, that is basically a joint space that is completely obliterated, completely collapsed. This is what it should look like. You can see that nice space that's there, and the cartilage is essentially gone and completely eroded. And this articulation at C5 and C6, again, you lose a lot of detail through here, right? You should see this nice space like we saw on the previous slide and on these images here, but you can't see that so much in this picture. And even as we go back to C6 and C7, there's a little fragment there. So these are pretty advanced arthritic changes. I would expect a horse like this to have pretty severe neck pain and or neurologic deficits due to compression of the spinal column. The changes in this one are a bit more mild as far as centrally through the spinal canal is concerned, but we do see these fragmentations and arthritic change at C6 and C7 here. So varying degrees of change that we can see, and it's really important to consider what they mean in these more mild cases. So one way that we can further evaluate the meaning of those changes is nuclear scintigraphy or bone scan. So this is an imaging technique where the horse is injected with a radioactive isotope intravenously, and that goes through the body, and that isotope attaches to areas of active bone turnover or active bone metabolism, bone remodeling in the body. So typically osteoarthritis, fractures, bone cysts, and pronounced bone edema. Then, there's time that it takes to penetrate the bone and create an image. And there's a specialized gamma camera that is used to obtain an image like we see here on this slide. This is of a normal cervical spine. As you can imagine, there's constant bone turnover happening in the body. So the bones are always remodeling in any given species. So we use that in our favor because it helps us generate an image. And we then look for areas of asymmetry or stark increased uptake. So like I said, this is a very normal spine. The facet joints on the top and on the bottom, you can see where they articulate, and they're brighter or darker in these images simply because they're superimposition. This is basically the spinal column here, or spinal cord, so essentially no uptake as we go through that region. And what we look for again is stark changes or stark contrast from one vertebrae to the next, or from one side to the other. So these are very symmetric in the amount of blackness or the amount of uptake that they had. If this was, sorry, my cursor keeps running away here. If this was the color of this here, then we would be concerned that that would be consistent with significant change or significant remodeling and active clinical disease. I have more pictures of bone scans later on related to the back to show you that contrast, or at least what I'm talking about here. So moving on to another imaging modality, this is a myelogram with plain radiographs. You can also have a myelogram with CT imaging. And the myelogram is generated by injecting a radioactive dye into the epidural space. So this bright white column that you see going down here and down here along the bottom of the vertebral canal, that is the dye column, and it surrounds your spinal cord here. So in horses that have, young horses that have wobblers, where there's instability between the vertebrae, the myelogram is very useful in determining whether there is dynamic compression of the spinal cord as the vertebrae flex and extend. And in older horses, which is a different type of wobblers, it's type 2 wobblers, those ones, the myelogram is helpful for determining static compression, so that when there's enough bone proliferation here or arthritis in these areas of the facets or the joint articulations, that it actually creates compression on the spinal cord through the canal, which is what we're seeing here. So we see a significant reduction in the height of the die column in these areas, indicating active compressive disease. There's a lot of other bone pathology that can happen in the neck. Like I said, they can certainly sustain fractures to the vertebral column. They can also be sites of OCD lesions or other developmental abnormalities. Congenital malformations occur as well. I'm not going to spend a whole lot of time on these because they're not poor performance issues. These are often developmental issues that are identified in younger horses. And aside from the fractures and subluxations, those are very acute traumatic events that we often know when something has happened, and there's a very discrete implicating cause. So just touching base briefly on congenital malformations, these are quite rare. The most common is what's called an occipito-atlantoaxial malformation. So that is a malformation of the junction of the skull and the first two vertebrae. They can be, there's a lot of variation in the way that they look or the malformations that do occur there. But these horses are identified at very young ages, typically as foals. It's most commonly noted in Arabians, and they often have a very abnormal contour to the neck with varying degrees of neck mobility. So they might be sort of locked to one side versus the other, or locked in sort of a flexed or extended position and really unable to move the way that they should. And radiographs are generally recommended when we see something like that, and then we identify this congenital abnormality. That's, like I said, the most common congenital malformation. Other ones that occur are called block vertebrae or hemivertebrae, where there's portions of the vertebrae that are missing or abnormally shaped. And we typically get pretty obvious neurologic deficits associated with those. So those are identified in very young horses and are not causes of poor performance. The developmental orthopedic diseases, again, generally identified in younger horses, particularly growthy horses for OCD, and they may have other OCD lesions in other joints, the hocks, the stifles, the fetlocks, what have you. And then the cervical stenotic myopathy, those are the wobblers that we briefly talked about, where there's instability between the vertebrae that creates compression of the spinal cord. And those horses do have pretty obvious ataxic or neurologic deficits with their gait. I have in very small letters down at the bottom of the screen there, neoplasia and osteomyelitis, again, very uncommon in the horse, and usually not so much a cause of poor performance, but more an acute onset of neck pain or inability to move the neck as they should. Frequently we'll get complaints that these horses stopped eating. They suddenly are unable to put their head down to the ground to eat their hay or into their bucket or to graze on pasture. And we find usually pretty advanced lesions at that point. Neoplasia is exceedingly difficult to treat in the neck. Radiation therapy is extremely cost prohibitive, and there are very few locations in the country that can treat a horse with radiation therapy. So we're not going to talk about treatment on that. And then osteomyelitis being a bone infection, that again is typically seen in younger horses or horses that have some sort of systemic infection, septicemic disease presentation, so bacteria in the blood and circulating through the body, and then it seeds the particular vertebrae. Again, can be quite difficult to treat and is not a cause of poor performance. So other problems in the neck are soft tissues. There's lots of soft tissue structures in the neck. The nuchal ligament attaches to the base of the skull, basically comes out from the withers, and in a fan-like pattern goes and attaches down to each of the cervical vertebrae and to the base of the skull. Frequently we can see mineralization at the attachment of the nuchal ligament to the base of the skull on radiographs. And again, these can be very incidental findings seen in a lot of warm blood horses. They're less commonly seen as incidental findings in thoroughbred horses, and that breed may have a predisposition to bursitis or true desmopathy at that insertion that might need to be treated. Horses that have insertional desmopathy or nuchal bursitis typically have discomfort or may have a history of pulling back when they've been tied, or a fall, or more commonly in performance horses, the repetitive strain on that area due to excessive lunging, typically with side reins or draw reins. So when their head is, in a very fixed position for longer than expected or wanted period of time for the horse, that can put a lot of strain on the back of the skull and at that insertion site for the nuchal ligament. They frequently don't show clinical signs unless they're actively being lunged or being ridden in that frame, and they will have resistance against the rein to the rider, or difficulty or unwillingness to lower and flex the head and neck like they should. Sometimes they'll shake their head, and occasionally horses with severe changes will rear. But usually these horses are not painful to palpation of the back of the skull or the base of the skull, which is very different with horses with nuchal bursitis. Those horses are painful to palpation and frequently have soft tissue swelling in that area. So that's one way we kind of suss out the difference between those two things. For nuchal bursitis, treatment is surgical to debride those areas and treat with antibiotics if there is an infectious component to it. Treatment for insertional desmopathy is similar to other treatments for the back or kissing spine type lesions. We're frequently injecting these areas with a corticosteroid or an anti-inflammatory to calm down that inflammatory process and allow that pain to subside. We do frequently treat those horses with shockwave acupuncture as well, and local massage to, again, calm down the inflammation and calm down the pain that's there. Muscle pain can be difficult to interpret in this area. There are not a lot of horses that have true cervical spine issues that also have neck soreness associated with it. And there is a group of horses or a subset of horses that have pain at the base of their neck, particularly if you put pressure right where the neck inserts, basically on the trunk. And those horses can sometimes be confused with horses that have neck problems. Often the pain at the base of the neck is associated with mild forelimb lamenesses as they brace their neck when they land on that foot to take some weight off of it if there's lameness there. If it is true muscle soreness that's not related to a lameness problem, those horses generally respond well to rest, physiotherapy, massage, shockwave, acupuncture, all those sorts of alternative modalities. So again, treatment here, we briefly touched on these things. Shockwave, mesotherapy are non-invasive methods of treatment. Cervical facet injection, so that is basically steroid injection into the joint that may be affected by osteoarthritis. And then chiropractics, massage, and acupuncture, we frequently use those all together once we've sort of more directly treated the area that we have identified a problem in, and a lot of physiotherapy, so stretching, rehab, and appropriate riding or appropriate training aids to prevent additional injury to those areas. Other treatments, including gabapentin and methocarbamol, so muscle relaxers, and then gabapentin is used for more neuropathic pain where the nerve roots may be compressed by the excess bone proliferation. Those can be helpful adjunctive treatments to all those other things that we've discussed. NSAIDs I have on here. Long-term use of NSAIDs is really not feasible because of the secondary complications we can get with the gut and the kidneys. However, if we are trying to decide if a behavior is, or a clinical sign, bucking, bucking, rearing, refusing a jump, neck stiffness, those sorts of things, hanging on the bit, if they are related to an actual behavior, a poor behavior in the horse that may be learned, or a pain-related response, a trial with NSAIDs is often helpful.
Before we leave the neck, there was a question about, is the nuchal ligament bursitis issues that you talked about, are they the issue with Rollkur? Is that why Rollkur is frowned upon?
That is certainly one of the problems that we can get with that. That particular frame where they're really curled under and rolled under puts a lot of pressure on the rest of their spinal column as well. So through the back, including everything is connected, right? Like a rubber band. So that nuchal ligament goes down over the withers and then connects with the dorsal spinous ligament that runs down the rest of the back. So it can create a lot of issues, not just with the nuchal bursitis or insertional desmopathy, but through the back as well. All right, so just a couple images here showing treatment of the neck. So this is just an ultrasound image. Here is basically the needle that would come in. This would be the cervical facet joint. And I'm gonna try and play this video here and see if it works. No, I guess that one does not work. But this is just, like I said, a solid picture of the needle going to the cervical facet joint where we do ultrasound guided injections of these locations. This video I think will play. So this is the area we're looking at here. So this is the needle. It's a little bit hard to see where it is, but you can see we're injecting fluid into this and the joint capsule is filling with that fluid as we inject it. So that is what we look for when we treat necks, that our steroids are going to the right spot. So what, does this all mean? Prognosis for horses with neck issues. If you've got a horse that has a cervical facet arthritis, unfortunately, there's not a lot of data out there that has followed these horses long-term and how they respond to corticosteroid injections. But we know just from clinical experience that direct treatment of areas where we know there is arthritis can be extremely helpful. And we typically do need additional modalities though to calm down the rest of the secondary soreness that comes with it. Prognosis is often related to severity of disease as well. So if we have horses that have very advanced arthritic change, may have stumbling of the hind legs or forelimb lameness associated with it, those horses do not typically respond long-term. Unfortunately, arthritis is a progressive disease, and over time, while we can slow down the process, it will progress. So it's ideal if we can find these things early on and start treating them to slow the progression. And when we find them when they're pretty advanced, we unfortunately have less options for treatment in this area. So I'll stop quickly there before we move on to the back, if there are any other questions.
It's about 20 till. Want to make sure you are on track with time. Yep,
I think we can slide through the back a bit more easily because the treatment is much similar to the neck, so we won't have to talk much about it.
Perfect.
All right, so moving on here. The back, particularly the thoracolumbar region, it's a very complex region in the body. There is a lot of muscles. The spinal column is very complex in its anatomy, and there are a lot of ligaments here as well. So similar to the cervical spine, but even more so enhanced because of the apaxial musculature in this area. This is just a cross section of the lumbar region of a horse to illustrate how much muscle there is around here and how difficult it can be, or to explain how difficult it can be for us to image the back and the lumbar region, the lumbar spine of the horse. So we have to have extremely high power with our X-ray equipment to penetrate through the muscle and get good images, which is why diagnosing problems in this area is very difficult, and sometimes we cannot even obtain an image in a very heavily muscled horse. So this image helps for leading into kissing spines. This picture specifically illustrates the spinous processes in the back. So on the right are the vertebral, or just the bone, the dorsal spinous processes here. These are the vertebral bodies. The head is to the right in these pictures. And this shows the ligaments that are associated with it. So this is the interspinous ligament here between the vertebral bodies, and then the dorsal spinous ligament that runs right across the top. Down further, we can see this joint here. That's the articulation between two of the vertebral bodies. So one of them has been removed in this picture just to show that it is truly a joint, just like any other joint in the body. There is synovial fluid there and is subject to arthritic change. So horses with back pain present with very similar, unfortunately, clinical signs. So horses with neck pain, poor behavior, bucking, even resistance to girth pressure or bolting. Those are a bit more specific to back pain, and we can utilize Butte trials to help determine if it is truly pain related or behavior related. These horses do frequently have reduced jumping ability and, again, hind limb lameness or reluctance to use their hind limbs freely are frequent complaints. I put this in here just to remind everybody that the entire body is connected, and in the absence of a known traumatic injury somewhere, when we have acute onset or a sudden onset of lameness or behavior, it's really usually just a manifestation of chronic pain that's finally surpassed the pain threshold of that animal. So, you know, I frequently get horses or clients that are telling me that this just happened. There has to have been something that initiated it. But unfortunately, what we find is just degenerative changes that have accumulated over time. So consider that as we go through this. So the examination for back pain, again, it's very similar to the examination for neck pain. There's a static portion, palpation and manipulations of the back, looking for sensitivity and range of motion. And then the dynamic exam, watching the horse travel, doing flexions and seeing if there's concurrent lameness in the hind end particularly. And more specifically, we like to look at the hind feet conformation for horses with back or SI pain. So gluteal pain, I'm going to just touch base on podiatry quickly here. We can see these horses. This horse has a not particularly short back, but it has a shorter back than this horse here, which is a quarter horse. They particularly are plagued with long backs and long toe, low heel conformation. And when we draw a line from the coronary band on these horses to where it connects on the front half of the body, these long toe, low heel horses have a more steep trajectory to the coronary band than horses that have good hind feet conformation. They typically end right at the back of the knee, and they have a shorter breakover distance. And that's important because breakover distance puts a lot of pressure through the entire gluteal region in the back. You can even see this like tucked under conformation is most likely related to the conformation of the feet and is something that can be corrected. So in this horse, this was a case that we had. It was a 5-year-old thoroughbred used as a hunter. And the breakover distance here before appropriate shoeing was 30 millimeters. So 3 centimeters from the front of the coffin bone to where that foot would leave the ground when it walks or when it breaks over basically on the foot. Once we shod the horse, we were able to decrease the breakover distance to 5 millimeters. And this horse had dramatic gluteal pain that was essentially resolved within 2 weeks with no other treatments besides shoeing. And there is a paper out there that looks at breakover distance and gluteal reactivity in these horses. So the red bars are the horses that had gluteal reactivity or gluteal pain in association with the breakover distance of their hind feet. And you can see that that bell curve is shifted to the right compared to horses that have shorter breakover distances and are not sore in their hindquarters. So the feet are incredibly important. We don't want to forget about that when we're looking at the rest of the horse, looking at saddle fit and everything else that goes along with it. So back pain, the examination, this is just palpation, a video of palpation. We'll kind of skip over the videos because they're a little bit longer and they don't show a whole lot. This is a very normal horse, but we run our hands down the spine looking for reactivity, move the hips side to side, lift the tail, looking for any reaction there. Move the back and forth, push on the hips and pull on the withers at the same time and look for mobility in these areas. One thing we do look for here is, can the horse dorsiflex through its back? So every horse, if they have good range of motion through their back, should be able to lift and round their back when you just put light sternal pressure on them. If they don't do that, there's concern that they're most likely guarding some pain through this area, or we think about ulcers in those horses as well. But for this conversation, we're thinking about back pain. So diagnosis is complex, just like the neck, unfortunately. Blocking exams are difficult because, again, there are a lot of nerves there, and we have to use pretty long needles, unfortunately, to block the areas where we're concerned about. And frequently horses don't tolerate that without sedation, unfortunately. So it can make blocking quite difficult. Imaging is, again, what we rely upon. So nuclear scintigraphy or bone scans, radiographs, and then ultrasound of these areas. So this is a bone scan of a horse that has kissing spines. So here you can see increased uptake in these areas compared to the area that's directly behind it or directly in front of it. And here are the radiographs of that horse. Hopefully you can see there is narrowing of these areas with some bone resorption and bone sclerosis, so increased bone proliferation, very consistent with kissing spines. Treatment, there's a lot of different treatment options, very similar to the neck: shockwave, mesotherapy, direct injection with steroids, chiropractics, massage, acupuncture, all of those things. The one thing that's on this list that was not on the list for neck treatments is surgery. So this is just an image of direct injection. We utilize radiographic guidance to make sure our needle's in the correct spot when we put our steroids in, very similar to ultrasound guided treatment of the neck. And when unfortunately steroid injections fail, or if it's elected as a first line, we do have surgical options. So this paper is from 2012, and it was basically the first paper that described a standing surgical treatment for horses with kissing spines. So this is the preparation for the surgery, placing the needles at the locations where there is very narrowed or overriding spinous processes. And what we do is we make very small incisions along the side of the back, and we cut this interspinous ligament, thereby releasing the connection between the spinous processes. There is still that dorsal spinous ligament, the ligament that runs along the top of these spinous processes. So there's still a lot stabilizing this area, but the compression that you get from the interspinous ligament between the spinous processes is released. This surgery, I typically do not recommend it unless the horse has responded to medical treatment, because there's a different surgical option that's a bit more invasive if we have pretty advanced changes. And I can jump to that secondary option if needed, if the horse isn't responding to medical treatment of this particular area. If they don't respond to steroids here, unfortunately, surgical treatment with just cutting that ligament is typically not going to cut it. But that paper does describe a pretty high success rate, about 90% of horses able to return back to their expected level of performance. And they compared horses that were treated just with corticosteroids versus horses that got the surgery as their first line of defense. And there was about a 30% chance, or 30% recurrence of back pain in the horses that were treated just with the steroid injections versus no recurrence of back pain in the horses that were treated with surgery. So it is a much more long-term option. But again, I always like to have horses respond to treatment of that area before I recommend an invasive option like surgery. This is another more recent paper that evaluated the same type of surgical procedure, so the desmotomy of that ligament or cutting of that ligament. But this paper is only looking at English performance horses. So the first paper had a very high population of thoroughbred race horses, and those horses are very stoic, and if they want to run, they will run. English performance horses, I don't want to say they're a little bit wimpier, but they are a bit softer in their soles, and back pain is more important because there's a rider that actually sits on their back versus crouches over their back. And when we looked at specifically English performance horses in this paper, the surgery is not quite as effective. So only about 60% of the horses did not experience back pain after they had surgery and were able to return to their expected or higher level of performance. So there is, you know, it's not quite 50-50, it's a bit higher if we elect to do surgery on these horses, but it's not a quick fix, and it's not a guaranteed fix either. The last surgical treatment is a quite invasive treatment, and these are for horses that have extreme changes or very marked radiographic changes in their back, where we actually remove a portion of the bone to create more space for them. This is a very, very invasive surgery that we don't recommend frequently, but we do it sometimes. And then we take that one step further in certain horses, and we actually take off up to half of the spinous processes in horses if there is significant overriding of that area. This is a bone scan image just showing more of a, not a common location where we see arthritic change. That's down in those, the actual joints or articulations of the vertebral bodies versus up in the dorsal spinous processes like we've been talking about with kissing spines. So this would be an uncommon manifestation of back pain that we could see on radiographs. These changes we can see in combination with the kissing spines. But again, these are much less common, and we can treat these arthritic changes just like we treat them in the neck with direct injection with steroids via ultrasound guidance. Moving on quickly to SI pain. Again, these horses present with poor performance, potentially bad behavior under saddle, but more specifically for SI pain is a low grade or shifting hind end lameness, lack of hind limb propulsion, or difficulty maintaining the canter leads, and they can frequently wide step with their hind legs. On physical examination, we can see poor muscling through the croup or through the top line there, reluctance to stand on one hind limb, or difficulty holding a limb up for the farrier is another common historical complaint. Toe dragging or interfering can occur, and restricted flexibility through that thoracolumbar region often goes hand in hand with it. So back pain, or I'm sorry, SI pain can creep forward and cause muscle soreness through the thoracolumbar region. Again, I always say check feet in these horses. If we have long toes and low heels, that certainly can contribute to SI pain. This is just an image representation. When we put pressure on this area, horses that have pretty marked pain can knuckle through their stifles and can almost go down if they're that painful. Nuclear scintigraphy is the only imaging modality really to look at SI pain. The ultrasound evaluation is incredibly difficult to do and is not well described. And unfortunately, there's a lot of bone obstructing true imaging of the SI joint right here. So the bone scan images here, this is a very normal bone scan, very discrete tuber sacrale that we see on the pelvis here. And then abnormal, we see much more diffuse change. So sort of a blurred image through these areas of the SI joint. SI injection is something we very commonly do. It can be done ultrasound guided or a blind approach. So this would be the blind approach with a very long curved needle and using specific landmarks to help guide where we put the needle. Ultrasound guidance is what I do and what a lot of folks do now. We use the ultrasound, find the wing of the ilium, and then guide our needle directly under that to the sacroiliac joint. This is just an image of that happening. There is a cranial and a caudal approach. I typically only do the cranial approach. The caudal approach is done by lots of folks, but there are a lot of very important anatomical structures on the back of the SI joint that we don't want to hit. So the caudal or the cranial gluteal artery is here, the sciatic nerve, and then the rectum. Our needle is essentially going right to this area. And if we hit any of these structures, we can have pretty bad complications that we don't want to have. So the caudal approach can be done, but it can be done, it should be done with caution. Other treatments for back and SI pain, again, stretching and mobility exercises are incredibly important. Shockwave, acupuncture, pulsed electromagnetic field therapy is utilized by a lot of people. The MagnaWave is also out there now. Ribaxin, which is methocarbamol or a muscle relaxer, is used very frequently, and NSAIDs as well. Sorry, I ran through the back sort of portion very quickly. Any questions on any of those things?
I think we want to know who this is.
This is my horse, Pearl, Perfect Pearl.
If there are no more questions, then I want to thank you, Dr. Peel, for giving this great topic. I learned a lot. I hope that everyone that joined us also got some key takeaways. We appreciate you sharing your time and expertise with us tonight. And I know this is a very busy season for you. You were on call last night.
Yes, thank you for.
And I want to thank also everyone who attended. Oh yeah, you're welcome. You're welcome. That was great. We want to thank also the people who came and listened, and we hope that all of you join us for our fourth and final in the Vet Zoom series, which is Dr. Travis Henry, and he'll be covering horse dentistry. The date on that one is Wednesday, July 21st, same time, 7 p.m. And if I could ask just one more thing before you start falling off, please provide IDCTA with some feedback on these health webinars. So, you know, did you find them helpful? Do you want us to continue them? This was kind of a pilot test. What other topics do you want to hear about? How is the cadence of once a month? And are you know, Wednesday evenings at 7 p.m. good? So we just want to know, you know, how did this, what do you think? Do you want more? Do you want less? Do you want different? Do you want Dr. Peel every month? I mean, you know, we had to talk about that.
On behalf of IDCTA, Dr. Peel, I'd like to really thank you for spending the time with us and being in what we call our sort of kickoff series of things, educational things within the veterinary community. So thank you so much. I appreciate it. And I know that everybody that's on the call appreciate it. And those who will look at it on the website, because it will be posted on the website as well.
Very good.
Thank you very much.
Everyone have a good evening.
Thank you, everybody.
All righty. I'm going to end the meeting.